white teeth with a normal proportion and a broader smile. Of course, everybody wants that. So then we start our treatment, very straightforward. Again, straight wire mechanics. We are trying to bring the upper teeth forward in order to create more overjet. Together with intraoral scanning procedures, we are now able to monitor our treatment throughout the preparatory phase, so we can assess exactly what the planned position for the teeth is and where we are at the moment in order to moderate our tooth movement better. Finally, we have arrived prior to surgery, and we perform again the traditional records for the patient. We assess that the inclination of the upper incisors is checked in the articulator. Then surgery is performed in the articulator. And as you can see here, we can always double check back on the models if the splint is okay. If you want, you can also individualize the construction of surgical plates. And then, after surgery, patient comes back with the situation here. And then the prosthodontist decides to put some provisional posterior restorations on in order to get the patient out of the splint, which is not so nice to wear the splint 24 hours a day. So here you can see, after very close grinding and equilibration of the situation, we are finally stabilizing the final treatment result before appliance removal. We can still check together with the prosthodontist if minor corrections are still necessary. This is pre and post treatment. After provisionals, sometimes 2 sets of provisionals are necessary, especially if you do these crown lengthening procedures. You're doing them in the lower and the upper arch, and finally the final crowns are fabricated in the lab. So you can see it's really a complex procedure in order to finish our patients with the best possible treatment outcome, and all this is only possible with close collaboration between the specialists. You can see we have raised the bite, we have provided sufficient space for the prosthodontic rehabilitation. You can see all the abraded teeth have been very nicely restored. 1 implant has been placed in the 4th quadrant. You can see the dramatic change after this very complex treatment approach. So it's really life-changing what you can do here for the patients, but teeth is very happy. But all that is just possible if you work in very close collaboration with all the involved specialists. And it's a lot of work, and it needs a lot of engagement from all sides. So let's go a little through the patients.
Then I may share with you Daniela. She is MD, a medical doctor, who came to us at the age of 46, having seen already by several professionals. This is her situation. She came because she was afraid to losing the She has an impacted, severely impacted lower right molar. The story is quite long. Class 2, Division 2, belt impingement, maxillary retrusion, chronic periodontitis with involvement of several teeth, loss of some teeth, and impaction of this 48 of this third molar. The story is long. She has been seen by a maxillofacial surgeon who told her, leave this third molar there, don't touch it because it's too dangerous to remove it, otherwise we can hurt, or I can hurt the nerve. And so she came with this information. And she had also very hypoplastic maxillary incisors, hypoplastic teeth in general. Third molar, we wanted to extract 28 and 38. We sent her to our periodontologist. 21 should be maintained. The pre-surgical orthodontics should level and align the arches, upright in the molar, correct upper and lower incisor torque, coordinate the arch forms, and then a bimaxillary surgery has been planned with the genioplasty. And afterwards, reconstruction of the hypoplastic and worn teeth. And of course, she had to replace the missing teeth 37 and 44. So, the story is quite long, because we are talking about interdisciplinary therapy, and it seems to be very simple and very easy, but it is not at all. It starts with the impacted third incisors. And now she comes back to us and says, this is what the surgeon is saying. And we encouraged her, you have no other chance. There's no other possibilities for you to go this way. And the surgeon was saying, I don't operate, I'm reluctant to operate patients older than 30 years. What should we do with her? She's 48. And he is saying periodontal problems which can only worsen with, get worse with orthodontics. Which kind of preparation could you achieve? He was talking to us. I doubt that the lower curve of speak can be leveled without losing the anteriors. In the same operation, during the same operation. And we had, afterwards, we had to do very little after the surgery, just some assessment with elastics, in order, and to end up in a situation like this, some wire bending, and provisional composite restorations after the bonding, prior to implantal prosthodontics. Pre-treatment and the whole treatment took us exactly 12 months, including the surgery. And we finished in a situation like this. Now we sent her to our friend, the prosthodontist, with a situation like this, pre-treatment, after treatment, nice arch folds, nice coordinated arch folds. The tooth 45 is still there. The periodontal situation has improved, not deteriorated. If you look at the periapicals, the big apical radiographs, before and after. With orthodontics, we can improve periodontal involvements, but they have to know how to do, how to prepare the patients. Ceph before and Ceph after, panoramic X-ray before and after, and it's the situation after substitution of the missing teeth, after prosthodontic rehabilitation, and this is the lower curve of speed, totally leveled. What is very important? Before and after the completion of this 3D approach, and we call this kind of patients complex adult patients, where several professionals are involved. And the whole treatment with prosthodontics and implantology took us 18 months. 18 months. It's a reasonable time. Look at the deep eye before treatment, look at the situation after treatment. Smile before and smile after treatment. Change begins at the end of the comfort zone. And we know that. We know what the patients are thinking at the beginning when they come to us. Yes, patient. This is Maria Rosa. She comes to you and she is asking you, can you do something for me? Her dentist sent us her to referred her to us. her dentist, because her dentist is our friend, is a friend of ours. Here, acknowledge that she needs us. He's not able to do anything for her in a situation like this. This is her situation. Look at the bite. Missing lower molars. Missing a lot of teeth. What can a prosthodontist do with her without our help? She was complaining, I can't chew anymore. There was no space for a prosthodontic height. Extruded posterior molars, granuloma, superior endo defect, deep caries. What else would you like to have? Begin with that in mind. Maintain all bridgework and hopeless teeth for orthodontic anchorage and reduction of costs. Extraction of 18, separation of the bridge 1122, provisional crowns on several teeth. Pre-surgical orthodontics, very simple leveling and aligning we correct in order to give her a correct incisor dog. Coordination of the art forms. And then we sent her to our friend, maxillofacial surgeon. She needs him. BSSO with advancement, pre-implant, bone graft, genoplasty. And then, of course, she needs some teeth. And she comes back in this situation after surgery. Now you see that there is enough space in the posterior area to replace some molars. The day of the bonding, 11 months of treatment. Not even a year. There is enough space to replace these missing teeth. Of course, the surgeon increased her lower face height. And concomitant with the bilateral mandibular advancement, he did a pre-implant bone graft on both sides. Pre-treatment. And as you can see here, bone grafts have been performed during the surgery, involving orthodontics, maxillofacial surgery, implants, and prosthodontics. These are for us complex adult patients. 21 months of orthosurgical prosthodontic treatment. Arch forms before, arch forms after this complex treatment. Composite restorations after the lower incised edges for functional stability, as we do always. Occlusion before, after surgery, and after a complex orthodontic treatment, orthodontic surgical prosthodontic treatment. Profile before and profile afterwards. Situation 8 years later. Nothing has particularly changed. Stable occlusion. Nice. Smile, full smile. No worn lower incisors, even though we have reconstructed them just with composites. These are, for us, complex adult patients, not 28 new teeth. Should we go on with her?
Of her upper dental midline, as you can see. She has also a deviation of her chin towards the left, but this doesn't bother her so much. What she doesn't like is this severe upper midline deviation to the right. You can see she is pseudoprogenic, has lack of support of her midface. This is the intraoral situation where you can all detect a severe midline discrepancy. It's a 1.5 incisor tooth width. Why is the upper midline so very deviated to the right side? You can see 2 teeth are missing in the first quadrant, and of course you see also that the first molars are missing in the lower arch. Again, we don't think that it's possible to perform a conservative treatment without involving the oral maxillofacial surgeon. So if we put all these features together, her dental and skeletal problems, for us, she is for sure a combination before we touch the patient, so we know that we have to perform pre-surgical orthodontic dental compensation. We have to create space for one tooth in the first quadrant because 2 teeth are missing there, and at that time we decided to open a space for the missing upper lateral incisor on the right side. It's an old patient. Probably we would have opted for another solution nowadays, but in 2004 this was our treatment plan. In order to shift the upper dental midline to the left side, a compensatory extraction of the first premolar was planned in the second quadrant. And we planned, because we needed to perform dental-alveolar decompensation prior to the class 3 surgery, we had planned to open 2 spaces for third premolars in the lower arch. So a third premolar on the right, a third, and as we said before, 2 implants for crowns for third premolars in the lower arch. And so we started our treatment. And here you can see Margit during the course of pre-surgical orthodontics, and you can see that the upper midline is already improving, but we are not where we want to be. So when we take a look at the before and the after situation, this is now 12 months into treatment already, you can see there was improvement, but the upper midline is not yet corrected, and there's not sufficient space for the upper lateral incisor implant. While we have created very nicely the space for the third premolar. So we were able to decompensate as we had planned. But the problem was that I was not able to open the space sufficiently for the implant. And this is the beauty if you work very closely together with the team, and you should, that sometimes one of the team members can help you during the course of treatment. One osteotomy in one piece for advancement as originally planned, but we can do it in 2 fragments, which allows me to rotate the left fragment to the left side, which will center the upper midline and will concomitantly open more space for the future implant. And by the way, there would also be the possibility, if I changed my BSSO plan in the lower arch, if we added a segmental osteotomy to close the spaces in order to avoid the 2 implants for the third premolars. So by adding segmental osteotomies to the BSSO procedure, which of course is a risky procedure, it's much more complicated for the surgeon, it would be able to spare Margit the 2 implants in the lower arch, which is very interesting. So here you see what was planned, and I said, well, that's a fantastic idea. If you are willing to do it, then go for it. And here in order to avoid the implants. Very nice job also with correction of the asymmetry, as you can see here. Before surgery and after surgery, bimaxillary surgery, I admit that both jaws could have been advanced a little further because the profile is quite flat, probably for our modern aesthetic trends. But the main problem was nicely addressed, as you can see. When you take a look at the upper arch symmetry, you can see that we have corrected the dental midline perfectly. You can see the implant has been placed. There was sufficient space mesial and distal to the implant, as you can see. And in the lower arch, complete space closure was achieved by this additional surgical procedure, which was great. Occlusion also holds very nicely. So not all implants in the aesthetic zone in the end need to exhibit signs of infraocclusion. We think that a lot depends on the final treatment outcome of the occlusal stability you give to your patients. So again, before, after, and 13 years in retention. And this is the last patient.